have any ideas kind of what are the areas of need still in large cell lymphoma?
Echoing the comments you heard, I think those patients who progress after CAR T and a T-cell engager, we probably have an unmet need there. I think the other huge unmet need is a lot of these patients are treated in community practice and they never get to these novel therapies. And so how do we expand access to these treatments that we clearly know are effective? The safety can be manageable. We need to educate everybody so that we get more access to patients where they live.
And I think on that point, the exciting developments with CAR T and bispecific, as Dr. Nastoupil just mentioned, are sometimes difficult to translate into practice where the vast majority of patients are treated. And so an advantage of a pill, golcadomide or acalabrutinib, are being studied in frontline large B-cell lymphoma is that they will be more easily translatable into a community practice. We saw the improvement of progression-free survival by adding polatuzumab to frontline chemotherapy as a replacement to vincristine. That looks schedule-wise a lot like R-CHOP, and so it's not logistically complicated. Adding in a bispecific antibody, adding in other complicated therapies with monitoring programs can be a logistical barrier that sometimes may not be able to reach the community quite as well as we would like it to. And so I do think that there's a big role to play for ease of therapy.
Right. And I think that's obviously will be the holy grail going forward, trying to figure out how to get these therapies to the community. You mentioned golcadomide, so it's CELLMod, but IMiDs have a long history in large cell lymphoma. Are you guys fans? So Revlimid, anybody using Revlimid in large cell lymphoma?
I mean, I've used it in clinical trials, so we've seen the combination of BTK inhibitors plus Revlimid to be a highly active combination in clinical trials, both in the relapse refractory space as well as in phase 2 trials in the frontline space. Obviously, we had the randomized trials, which showed kind of a plus-minus response compared to R-CHOP adding lenalidomide. We had a bit of a mixed picture, but I think that is in part due to dosing and to schedule, and I think if we had a better version of Revlimid, it could certainly have a greater impact in large cell lymphoma.
Yeah, and so golcadomide obviously is the newer CELLMod, which focuses mostly on the cerebellum function of lenalidomide, and it is in clinical trials that some of which are being presented at this ASH meeting. What do you see its role being in the current landscape? How do you see it fitting in with the current therapies that we have?
I think one unique aspect is it is oral, but it also has a toxicity profile that most oncologists are very familiar with, neutropenia. And so we have tools in our toolkit to manage that. It's agnostic to cell of origin, so that opens the door to a larger population of large cell lymphoma, and we know we can combine it with either chemotherapy or novel T-cell engagers, and so I think it provides an opportunity for novel combinations, as Swetha's mentioned, a larger population of patients, and a toxicity profile that most oncologists are comfortable managing.
So when you say agnostic to cell of origin, so we all are familiar with the early data on Revlimid. We don't have as much data with golcadomide on this front. Do you think cell of origin still matters, or have you moved on to kind of the newer classification systems?
I think cell of origin is easy to derive that if you're using immunohistochemistry, and I think essentially all centers in the United States have that information that's readily available when they're making a decision. I still think most are using it to decide if they're going to add polatuzumab into frontline, all with the nuances of it not really being powered in the Polaric study. I still think we look at that information. It tells us something about the underlying biology. There's probably huge limitations in how we currently define it, but I think most still are curious about that and are probably using it to inform some of their decisions.
Swetha, do you have something to add?
Yeah, I mean, I would say just echo that in that, we need better precision strategies in how we tailor our therapies, especially as we have more novel therapies. But I think it's still very easy to use. And I think a lot of us still look at cell of origin and sometimes tailor our therapies based on that, like the addition of polatuzumab. I think Golca, like Loretta mentioned, at least in the data that's going to be presented, seems like it's effective regardless of cell of origin. So that's interesting because LEN typically has been associated to have perhaps more activity in ABC subtype. But I think also, as Loretta mentioned, I think the toxicity profile is what's more exciting compared to lenalidomide, while neutropenia is manageable. Some of the non-hematologic toxicities like fatigue, rash, GI toxicities, at least in the data, the abstracts appear to be less frequent and severe compared to lenalidomide. So I think that makes it a more easy drug to combine with other agents.